Good evening, everyone. Just waiting for a few people to join. Okay, good evening, everyone. Welcome to our webinar on cataract surgery and special lenses. My name's Vicky and I'm your host this evening. Our expert presenter is consultant ophthalmologist, Mr. Alfonso Perez. The presentation will be followed by a question and answer session. If you'd like to ask a question during or after the presentation, please do so by using the Q&A icon, which is at the bottom of your screen. This can be done with or without giving your name. And please note that the session is being recorded if you do provide your name. If you'd like to book your consultation, we'll provide contact details at the end of this session. I'll now hand over to Mr. Perez and you'll hear from me again shortly. Thank you, Mr. Perez.
Well, thank you very much, Vicky, and good evening, everyone. Thank you for joining this webinar about one of the most common conditions, I think, that we treat in our clinics, and especially at Benenden and the Benenden Eye Unit. So I'm going through a few slides to share with you, and I'm going to try to explain to you a bit more what is exactly what we do when you are coming with a cataract, how we treat and what the options are available and what options we can offer you in general, and especially at Benenden. This is me. I am one of the consultant surgeons working at Benenden. And as I mentioned to you, I will talk to you about myself, but then I will just move and talk to you about cataracts. What are the types of cataracts? What are the causes, the symptoms, and finally, all the treatment that we can provide you, and as well, what care you need to have after your surgery. And not only immediately after the surgery on the first post-op recovery days, but also a bit later. So you may have heard, I will explain to you later, that some patients were having very good vision, and after months or years, the vision decreases a bit, and most of the time it's nothing serious. It's just a small treatment required to bring that good vision back the patients usually have after cataract surgery. And at the end, obviously, I will be very happy to answer any questions that you have. So again, this is me. I am a consultant ophthalmic surgeon. I initially trained my core ophthalmology, the training in Spain, Barcelona, where I am coming from. But then I continued my training at the UK. Currently, my substantive NHS consultant position is at Moorfields Eye Hospital in London. And my expertise is cataract surgery, corneal transplantation, basically, and refractive surgery. Working in a big unit, I see usually all sorts of complex cases, and those cases also include complex cataract surgery. I have registrars and fellows who are basically junior colleagues who are training to become a bit more subspecialists, and it's very common for me, to try to make them to improve the skills and the knowledge in all these conditions. And also I am an examiner at the Royal College of Ophthalmologists, where trainees, they usually have examination and they need to pass this examination before they become consultants. So cataracts, has been since the very beginning of the human history, there has been a presence. Mainly or mostly, you see that it's associated with aging changes in the eye. So everyone will have cataracts at some point on our lives. This slide is very useful to explain to you. It's a diagram actually of an eye that it could be any of your eyes. So I just hopefully that my arrow works. The eye has two main parts, for you to understand. One is the anterior part, which is all this area. I'm just pointing, and the posterior part, which is all this area in the back of the eye. So the posterior part mainly is formed by the retina and the optic nerve. So the retina is here, all this yellow area, this yellow surface, and this is the optic nerve. So in the anterior part, we have two main lenses. One is the cornea. This is my specialty. I'm specialized in this part of the eye as well, which is a curved, transparent structure, and it's a powerful lens. And there's another between the cornea and this other structure that you see here, I'm pointing, there's the iris. The iris is a tissue that gives color to your eyes. And this is in between. But here, this is the crystalline lens. There's another lens. So it's the second powerful lens that we have in the eye that help us to focus the images. So the light comes through your cornea. The cornea has a power, a refractive power, basically bends the light rays, and the crystalline lens, which is here, help to bend that further in order to focus this on the back of your eye, on the retina. That's what you see. So when that happens, you can see a clear image. You can see here the colors, the contrast, sensitivity, and all of this is the quality of vision. So what happens when this lens, mainly or basically due to aging changes, becomes cloudy? And that's when it becomes cloudy, we call it a cataract. So that's the name we used to, well, for a long time. It doesn't mean actually anything related with a cataract, but that's the name. So when it's a cloudy lens, the light has problems. The light will not go through completely because it's not transparent anymore and it's not elastic anymore. So the crystalline lens also help us to focus when we are looking at close distance, and it becomes a cataract, so you lost completely all of that function as well. You lost progressively function of accommodation, that's the name, to focus on a close distance when we are in the middle 40s. So then is when we need reading glasses, right? But even with we just losing that function, with glasses we still can see, unless the cataract, the lens becomes cloudy, and then is when we call a cataract. So when you have a cataract, the light will not go through properly to the back of your eye, and then when you see all these blurry images, and also the color, the intensity of the color and the quality of the image is seriously compromised. Now that's the cataract, just in gross terms. Just want to try to explain to you. So this is another diagram where you see more or less the same, the anterior part of the eye with all the names, and the posterior part of the eye, and that is the eye with a person with a cataract that we see on examination. So on examination, we see the patient on a slit lamp. It's like a microscope. Obviously, the eye is a very small structure, and we need microscopes just to properly look at it. So this is the most common type of cataract. We call this nucleosclerosis. And you can see this color, here, it's a brown yellowish color. Normally, this should be a transparent structure so that you wouldn't see any coloration here. But that's more or less the aspects of the eye with a person with a cataract, a nuclear cataract, right? So the lens that I mentioned to you, this structure, has two main parts. Was the nucleus, which is in the center, and the cortex, which is in the periphery. And all of that is involved in a membrane, which is an envelope. And that's important when we do cataract surgery, as I will explain to you a bit later. So this is the most common type of cataract, is the nuclear cataract. And this is what we see when a patient comes to our consultation with a decreased vision and no longer able to improve the vision with glasses. There are other types of cataracts, as I mentioned to you. If the cataract is mainly on the exterior part of the lens. We call this a cortical cataract, if the cortex is more affected, and sometimes have this aspect, is a whiteness, a bit of whitish coloration. Now this is a cortical cataract. It could be also not only the anterior part, also the posterior part affected, and this is a posterior subcapsular cataract. We see all of this opacity in the back of the lens, or the crystalline lens, not much in the center or nucleus, but mainly in the back. It's quite typical, this type of cataracts, in some diabetic patients, and this cataract progresses quite quickly. So a patient could be seen usually, okay, reasonably well, and then starts decreasing the vision, and in a few months the vision could be really bad. So this is kind of the cataract that can progress a bit faster than the other ones, right? And some patients can have also kind of congenital cataracts or congenital defects in the crystalline lens. And this is very tiny. So initially, there you see it's a posterior polar, that's a type of congenital cataract, but it can get worse, in the third, fourth decade. So these patients usually have symptoms a bit earlier. If you have a congenital cataract or congenital defect in the crystalline lens, that then becomes a cataract. So what are the causes of the cataract? I mentioned to you this basically related with age. That's the most common cause, and it's been always through a human history. And there are also congenital cataracts, as I mentioned to you. That's similar to this last or previous slide with congenital cataract. The cataracts can be also secondary to trauma, to injuries, right? If you have an injury in your eye, and if it's quite serious injury, you can have inflammation, bleeding in the eye. The eye can recover actually after this with treatment, not necessarily surgery, but later on you can develop a cataract much earlier that you could expect, by aging. And there are some conditions that also are related with the development of cataracts at an early stage. One of them is diabetes, as I mentioned to you before, and other conditions that require a specific type of treatment, which is steroids, either topical, just by drops, or like inflammation of the eyes, or systemic conditions requiring systemic steroids like tablets. That can also, these patients can also develop cataracts. And drug related, mentioned to you, is basically related with corticosteroids. That's not really that much common nowadays. We have lots of sorts of alternatives for many of these conditions. So cataract surgery is the only treatment for cataracts. There's no other treatment, unfortunately. No glasses, no contact lenses will improve your vision. And cataracts will only get worse. They do not get any better, even though if it's related with medication. You stop the medication, but the cataract will still progress. So what happens when you have a cataract? So when you have a cataract, obviously, the vision deteriorates. But interestingly, this progression of the cataract is very slow. So you will not see any kind of a sudden change in your vision or in your day-to-day activities. You will start noticing, and when you will compare, things that you are doing, so how it was, months or years before, and you were doing the same things. But as you can see in these images, one of the first things you notice is that the colors, intensity of the colors are not the same. And that's also related with the contrast sensitivity. It looks like much foggy, opaque, but initially you could be managing reasonably okay, actually. It doesn't mean that the cataract from the beginning causes significant visual deterioration. Not at all. Some patients really adapt well until to quite late stages of a cataract. But in general, you will notice that say, well, I used to be a better color, so I used to see better. I used to manage better looking, outdoor activities. I used to see the number of the buses that are coming, or recognize the people who are across the road, and I'm not longer just able to do that. So there's most of the patients usually say that, or patients who usually drive, they usually say that as well. So I cannot see much clearly, the roads. I can see the cars, are coming in front of me, but I not can see the details. Obviously, you will notice a blurred vision. And blurred vision is mainly related with the fine details in the objects. All right, so you can see a face, but you cannot see, for instance, the eyes of a person, or whether the person has glasses or not. And that's blurriness. Is when patients, when the blurriness starts, is when patients usually start just asking for help. They usually go to the optician and check the glasses, and the optician obviously said diagnose it with cataracts. And patients who are drivers or who drive cars, actually, even if the cataract is not really advanced, they can be managing really or reasonably well during the day, but at nighttime they can have halos, so they can be very uncomfortable for them driving at night, because the lights of the cars coming in front will cause a lot of glare. So basically a lot of light. And that's just related with the light that is going through the cataract, this cloudy lens that patients have in the eyes, and causes a lot of diffraction of the light. And that causes a lot of, glare sensitivity. So there's another very common symptom, actually. Patients say, it's difficult for me to drive at night now, even though during the day I'm reasonably okay. So when the cataract happens, the thickness of the lens, the size of the crystalline lens, it becomes cloudy, but also increases its size. And all of that causes changing in the prescription of glasses. So some patients will go to the optician to get the glasses updated, and they can improve the vision a bit up to a certain point, but that, because it is no longer transparent, so the quality of vision will not really improve significantly. And at the end, obviously, if it's quite advanced, you will have double vision as well, and that's all related with the cloudiness of the lens. All right. So what are the reasons for treatments? There's many reasons. There are basically clinical reasons, all right, and style reasons. So your life, the quality of life that you have is not the same. Maybe your vision is already compromised or deteriorated, rather than if you have a perfect vision. So there are some clinical reasons just to do a cataract. So as I mentioned to you before, the lens increases its size, and when it becomes a cataract, so there's less space inside of your eye for a circulation of the fluid. There's a fluid in the side of the eye that's constantly produced by some structures of the eye, and constantly draining as well. If the space reduces, you are at risk of having this condition, which is closed angle closure glaucoma. That's basically the pressure of your eye can increase suddenly, and that can cause a damage in your optic nerve, and then permanent damage in your vision. But it's not common nowadays. We're lucky in that the opticians usually are doing a good examination, regular examination of patients, because this is very common after 50 or the 6 decades of life. And patients at risk are referred a bit earlier and are treated a bit earlier. And we don't see these cases nowadays as 20 or perhaps 30 years ago, when cataract surgery was not that well established as it is now. So also some colleagues may not be able to see the back of your eye. So our specialty, as I mentioned to you, my specialty is basically the front of the eye. There are some colleagues basically who deal with problems in the retina and the optic nerve. They cannot see a clear image to assess your retina or assess your condition, if you have any condition in the retina, because the image is cloudy. So it's imagine like a window. If the window is cloudy, you cannot see outside of your house, but no one can see also inside of your house if the window is cloudy. So this is one of the reasons just to do cataract surgery, especially if a patient is diabetic. And also, the most important thing for patients is just your quality of life, right? So patients can come to us, are struggling with activities that they used to do or enjoy before, just shopping, cooking, driving, and patients are, going constantly or more often to the opticians try to update the glasses to improve the vision. And some patients obviously haven't noticed the impact in their lives and their activities, in their hobbies. So as I mentioned to you, there's no other treatment than cataract surgery. But the good news is cataract surgery is a very successful treatment nowadays. It's very well established and is kind of a straightforward procedure, I would say. And that's due to a really good developments, right, on the technology, actually. Cataract surgery is also very is very quick. I would say it's about 20 minutes, half an hour. The patients are usually inside of the operating room, and it's a painless operation. So patients, the eye is numbed, and it's not really any painful at all. So what we do usually, I will explain to you in another slide, is replace this cloudy lens, and that is obviously no longer allowing a good passing of the lights, focusing on the retina, just causing cloudiness. For a new lens, this lens is an acrylic, it's small, it's about 6mm lens, and it has some different parts. You can see actually the lens here. This is the new lens, all right? So we remove the lens inside of your eye initially with a special technique nowadays, and just replace this with this lens. So this is now inside of your eye, and it sits in the exact same position that the previous lens, but this lens is very thin. It's much smaller, so it's a lot of space in your eye then. So I remember that one of the issues in some patients may be the space. The cataract surgery usually sorts out that problem, right? The most common lens that we have here, or the standard lens, is the lens that we use in the NHS, and we call it monofocal lens. So what does it mean? Basically, the lens corrects your prescription, but just for one distance, right? We usually prefer to correct the distance vision, long distance vision. That's 1 meter and beyond, where usually are most of the activities perhaps that we do, except for some people who do a lot of writing or close work. But yeah, outdoors, TV, driving is okay. The lenses is okay. But these lenses do not correct another part of one of the other prescription that usually patients can have, which is the astigmatism. And the astigmatism is related with the curvature of your cornea, so the front of your eye. So most of us, or patients without astigmatism, the cornea is curved and the shape is more similar to a football ball, but some patients have it a bit asymmetrical and is more likely to have a kind of a rugby ball shape. It's just in the gross terms to explain to you. If that happens, obviously, you then need glasses to correct that. That's why some patients, they are short-sighted or far-sighted. But in addition, say you also have astigmatism. You hear this from your optician. You have also astigmatism, and that's corrected with glasses perfectly. So when we do cataract surgery, we can correct the monofocal lens, the distance, but we cannot correct the astigmatism with standard lenses or monofocal lenses, the lenses we usually use in the NHS. So what it means actually is your prescription is less, but you still will need glasses if you have astigmatism. And that's most of ophthalmologists, obviously, in the NHS public services, uses the monofocal lenses. But nowadays, we have also other options, for patients who would like to be as much independent of glasses as possible. And we call these special lenses. You will see premium lenses, different type of names. That's basically two main groups, right? And all these lenses usually correct the astigmatism to start with. So you can have only people who just want that, and the toric is the name of the lens. It can correct the astigmatism. So these patients will not need glasses for distance, but they will need reading glasses only, cheap reading glasses that you can buy, at Boots or any supermarket or any shops. But there's other groups of lenses that can also help you to have close distance vision independent. So that means that you can do things from close distance vision without glasses. And that's all called the multifocal lenses. And lately, there's a new version of a new generation of lenses we call extended depth of focus or EDOF lenses. You can see here, EDOF lenses that are kind of the most sophisticated type of lenses, perhaps, and has a bit of advantages over the traditional multifocal lenses that is just on the beginning of this slide, all right? What is the main difference? The main difference is that the multifocal lenses, they are very good, providing distance vision, intermediate vision without glasses, and short distance vision, but it can cause in a 10%, 1 in 10, a bit of halos, right? And perhaps the contrast sensitivity is just a bit reduced, but not significantly. I think most of the patients, they are really happy with the lenses. They don't notice any problem, but it's being described. So the new generation of lenses sorts out a bit that problem. So it's no halos, and the contrast sensitivity is great. It's similar to a monofocal lens. So it's a perfect solution. What happens is that the multifocal lenses, the trifocal lenses, gives you just a bit more of close distance vision. But if you are a person who reads a lot, who likes to read a lot all day, many hours, perhaps the multifocal lenses, trifocal lenses are still the best option for you. But if you are a person who does a lot of outdoor activities, drives, and you read normally not as much, perhaps the EDOF lenses could be the best option for you. So that all is determined in an assessment, right? So you come to the clinics, we need to do an assessment. We need to talk to you to know more or less what you do, what your activities, what's your lifestyle, all of this to determine what is the best option for you. So all of these lenses are very good on my point of view, and I have experience working with all these sorts of lenses, and patients are really happy. So there's another slide which shows you more or less in gross terms how the lenses usually look. The first one here, this is the monofocal lens. This is a less standard lens, that's I mentioned to you. See, the design can be a bit different, but in general, they are very similar. So you have the central part, which is the circular part, which is the optic. It's a small lens which goes inside of the center of the eye, where your previous lens was. And this is a monofocal lens. It's just a uniform surface. And these are just the arms of the lens that will help the lens to stay in a center position to allow your eye to see all the time. And these two of here, they are the premium lenses or special lenses. This is the multifocal lens. We just changed a bit the term with a trifocal lens, the lenses we are using more. And you can see has a lot of rings. And that rings helps your eye to focus on the different distances, the distance, intermediate and short distance. And the last generation lens has less rings. It's like only a couple of them here. You barely don't see it. The transition is much more smooth. But that's one of the keys, I think, just to reduce a bit the glare. The glare was associated with this lens most of the times. And with this lens, the problem has been kind of resolved, right? So there's more or less, you will see that most of the surgeons actually nowadays, we are moving towards this new generation of lenses. But we need to advise you that regardless of the lens that you have, there's no lens that perfect as a healthy, young, crystalline human lens, right? So the cataract surgery is a very good procedure, but even though it's a perfect surgery you can have, you may still need a bit of glasses for just the small activities, especially if you receive a premium lenses. The lenses work really well when there is a lot of light. In dim light conditions, you may struggle a bit for small print letter, and there's when patients may need some glasses, but usually they are the normal, over-the-counter glasses that you can have, in any shop. So what happens when you are diagnosed? You are coming to the clinic. We just do your assessment and, determine and talk to you and select the lens for you. If you are going to have a special lens or you're going to have a standard monofocal lens, the surgery indeed is very, very similar. It's quite the same, except for the special lenses, and to correct the astigmatism, we just need to check the position of the lens and leave the lens in a certain position in your eye. But a part of that is exactly the same. So obviously we prepare your eye. So we dilate the pupils to get access to your lens. We check your blood pressure, your glucose, and And if you are a bit anxious or nervous, we can give you a bit of sedation, oral sedation. But as I told you, it's not really necessary in most of the patients, right? It's normal to be a bit of apprehensive, I would say, if you are coming to a procedure, an eye procedure, an eye surgery. I would be surprised if you are not have this a bit of nervousness, when you come to have a procedure. But it's usually common, and we do this every day, and we have a protocol established, and patients do really well. So I mean, because it's a painless procedure, you just need to have the reassurance, all right, that this is a common procedure, and usually we all implement everything that is necessary for you to be comfortable, and obviously have a kind of comfortable experience, I would say, for your surgery. So cataract surgery, in general, has some steps, right? So what we do usually, we have a special trolley. Patients are sitting initially, and then the trolley just gets a bit flat. So patients are lying flat for a few minutes. The eye is anesthetized and cleaned, and the face is covered, just to keep it sterile. All this area we are going to operate. And you don't see much what's going on because your eye is dilated, the vision is blurry. You can see only shadows and lights, and you can feel perhaps a bit of pressure in the eye and the fingers, our fingers around the eye. And sometimes, we need to ask you to keep looking at the lights instead of the shadow. And because we open your eye and we use a small clip to keep your eye open, so you don't need to, open your eye at all. What you need to do is basically stay still and relax. And sometimes some surgeons, we prefer to put music. Some surgeons do not prefer to put music. So you can hear noises, you can hear conversations of the staff, but usually I prefer to have some jazz music when I am operating. So patients sometimes remember the surgery because I'll associate the surgery with a certain type of or a certain song that they were listening when I was doing their surgeries. But it's important not to move, right? It's the same when you go to the dentist. You need to stay still, open your mouth. The dentist will anesthetize your mouth actually to do the job. Here's kind of a bit similar. So what you need to do, the job of a patient is basically start, relax, concentrate, and do not move the head. And it's basically not difficult. So that's what you see when you enter in an operating room and you see a surgeon doing cataract surgery like this. It's sitting, looking through a microscope, looking to your eye, right? So the surgery takes about 20 minutes, as I mentioned to you, perhaps less. We usually do small incisions. So that means there's a 2 millimeter incision in your cornea in the front of your eye to get access to your lens and do all the job and do the steps of the surgery you can see here. A capsulorhexis means, as I mentioned to you, the lens is inside of an envelope, kind of, or a membrane. So we need to open that membrane, remove the lens, but leave that support or that membrane for the new lens. So the new lens will be sitting in that part of your eye. What we do is usually once we get access to the lens inside of your eye, as the nucleus, we use a special machine which has ultrasound in the tip. It's like a small needle. It's not really sharp, but it's like a small needle which vibrates high speed and dissolves the cataract, and at the same time aspirates your cataract. But the eye is also on constant irrigation, basically, so they just keeps the volume and keep it formed. So when that is done, we just put the lens inside of your eye, put antibiotics, and because incision is about 2.5 millimeters, we don't need to put any stitch. This is a wound sealing by itself. And then we cover your eye, but not necessarily just put an eye patch. So I usually leave the eye open because there was not really any need to do any strong kind of anesthetics in your eye. That's a diagram what we do. The capsulorhexis, as I mentioned to you, we open this kind of membrane, in the front of the lens to get access. And with the instruments, we see this, the phaco tip is the ultrasound tip that I mentioned to you. Remove all of this cataract, leaving the support, leaving this kind of a bag, empty envelope. And then you just put the lens. The lens is usually folded. It's an acrylic material. It's a foldable material. It's folded so they can go through this with an injector through this 2.5 millimeters. And when it's inside of your eye, it unfolds. It unfolds, and it usually stays in the correct position. So once you had your surgery, it's normal for you to experience a bit of discomfort. And most of the patients do not need any treatment. Some patients, take a paracetamol. And what you need to use is a lot of drops. And the drops are to prevent infection and obviously to control the inflammation and the swelling. But you go home without pain. And maybe the case that you have a bit of discomfort later on. So we advise patients, if that's the case, to take some paracetamol or ibuprofen and to start the drops as well. All right. And all the healing, all the recovery takes about a month, between a month and a half. So then the vision also improves in most of the cases quite soon, actually. In a few days, patients are having lots of improvement, but it can also improve. It can improve a bit later. So that's why we recommend patients not to get any glasses or not to update any prescription if they have the monofocal lenses, obviously, they do not have the lenses to correct the astigmatism until that time, until once you finish, until a month of the surgery, because the prescription can change. So the patients can have a bit more prescription at the beginning, and then at the end have less prescription. So that's why you need to wait. So once the cataract surgery is done, patients are discharged from the unit. Later on, you may have heard sometimes patients say, "Oh, my cataracts have come back." It's not true, actually. It's not the cataract. What happens, as I mentioned to you, the lens is sitting, in a special structure, which is basically a very thin membrane. It's like a bag, an envelope, but that membrane is very thin and transparent initially, and because the lens is not a natural material, it can have a normal reaction. The body can have a normal reaction to kind of isolate that structure from your body, from your eye. So that membrane, as I mentioned, transparent membrane, becomes a bit thicker and is less transparent then. And the patient notices this as a visual deterioration. But the good news is that can be treated, and it's not difficult. It's not surgery, actually. It's a laser, and the laser is done in the clinic, and it takes a couple of minutes, and it's a very simple, actually, procedure. And some patients, about 20% of the patients, may need that. And what the laser does is just cleans that central part of that membrane to allow, again, this complete passing, of the lights through the lens to the back of your eye, and then you can focus sharply as you probably you were doing it as it was before, kind of after your cataract surgery. So that's a YAG laser treatment. So that's the name of the procedure. It's not that the cataracts have recurred and you need a second surgery. Is that happens because a normal reaction in some patients, and what you need to do is just treat it with a laser. So I think I'm just finishing my presentation. So what I have to say is just Benenden is a very, very good unit. And as I told you before, I'm also working at Morphenside Hospital in London. But I really enjoyed working at Benenden, as I mentioned before. So I agreed to do this webinar a long time ago, but now I will still be working at Benenden, but in a few time from now, I will be leaving Benenden from Morphenside Hospital. I will be based in Morphens as well. But there's no really any other words of just gratitude that I have. And it's really been a pleasure, and it's really enjoyable place to work. And we have a lot of experience, some colleagues, which you can see here in this slide, who can definitely help you and treat your cataracts. All of them are consultants, all of them are very experienced surgeons, and you definitely are going to be in the very, very good hands at our unit. I think I'm just going to stop here. I don't know if you have any questions. I'll still be very, very happy to answer. I just leave it just to Vicky and Oliver to continue.
Thank you, Mr. Perez. That really interesting presentation. So as you said, we'll take some questions now. First question is from Anne, and Anne asks, do the anaesthetics used in cataract surgery contain adrenaline? She says she's had an alarming reaction with a lidocaine at the dentist, due, she thinks, to reacting with her bisoprolol medication.
Well, thank you, Vicky. Thank you, Anne. Well, the anesthetics do not usually contain adrenaline. So the dentists, they usually use adrenaline a lot because they want to prevent bleeding from your eye. That's not the case in eye surgery. But obviously, we sometimes use adrenaline to dilate the pupil. If a patient is allergic to adrenaline, we don't use it, and we still be able to do the surgery without any problem, right? We use another medication instead of adrenaline to dilate your pupils nowadays. That's more common. Adrenaline is not really common, so you should not have any problem at all.
Lovely, thank you. The next question is two parts from John. So John asks how a replacement lens is chosen, given that eyes vary in depth and different lenses will focus at different points. And he goes on to also ask that he's due to travel to visit an old warship where he'll have to bend down, which will be 2 days after his cataract replacement. So should he not go on his trip to see his warship?
Oh, thank you very much. Well, nowadays cataract surgery is is much safer than a long time ago, probably. But we do recommend patients just to wait a few days, not only because the risks that can happen if you have you bend your face, and it's just because you really need to look after you have to use some drops, and you need to just to take it easy because the lens is still not in a fixed position, and any movement, especially if you have special lenses, it can change a bit the outcome. If it's 2 days after your surgery, I would definitely recommend it to wait a bit more. I personally ask my patients to kind of stay home and just take it easy. You can go out, just walk, but no gym, no exercises, not traveling for a week. All right, even driving, I would definitely recommend a patient a week. And the other question was about how the lenses are chosen. I think that given that the eyes are all different, we have special tests for that, and there's a special machine we have to do the measurements of the eye. It measures the front of the eye basically, and measures the actual lens, so how long is the distance between the front of your eye and the back of your eye, and about the curvature of the cornea, as I mentioned to you. And all is due to a complex mathematical process that the computer does, and that usually calculates the lens, the best power of the lens, the best lens which is suitable for you. Okay, so every patient is different. It's like going a shoes shop. There's a lot of sizes of shoes, and patients need every person needs a different size. So in cataract surgery, it's quite similar. So the lens has a power, and every eye is different. Even it's not the same power of lens for each eye. It can vary between one eye and the other eye.
Okay, thank you very much, John. I hope that's answered your questions. Next, we have Bernie. Bernie is 65 and has the beginning of cataracts. They also have astigmatism in one eye, wear contact lenses and glasses. And Bernie asks, over the past year, my eyes water quite a lot. I understand this is known as dry eye. And does this condition affect the success of lens replacement?
Well, thank you, Bernie. Yeah, well, I mean, dry eye by itself, can cause also blurred vision, and the treatment. I mean, there's no cure for dry eyes, but what patients usually find useful is just try to keep the eyes wet as much as possible. Right, so you basically use artificial tears. I think you mentioned that you were wearing contact lenses. Well, contact lenses usually make dry eye condition worse, and that by saying that also the vision can get worse. If you have also astigmatism, that can be corrected with cataract surgery. So I think definitely you would benefit if you have some degree of cataracts, your vision is getting worse, of surgery, and the astigmatism can be corrected with cataract surgery. So that means that you have really good chances of being independent of glasses. So then if you ask with special lenses, whether you will be suitable for special lenses, kind of the premium lenses, the multifocal lenses, or the EDOF lenses I mentioned to you, that will depend on the assessment. You have to do some tests, in the clinic to determine whether your eye or you are a suitable candidate. But most of the times, patients definitely have options. There are quite a few options. As I mentioned, two main options in special lenses, and I'm sure one of them probably would be suitable for you.
That's great, thank you. Next question is from Robert. Robert asks, I have a moderate cataract in my right eye, which becomes more prominent at work, in an office under artificial lighting. Is there a stage the cataract must reach before you recommend operating, bearing in mind that I do not meet the requirements for a procedure on the NHS?
Thank you, Robert. That's a very interesting question, very good question. When I was at medical school, and that's, about 20 years ago, I remember one of the professors saying, because cataract surgery was much more risky at that time, saying that we need to wait until the cataracts are really formed to do the surgery. And that was because the risks were really high, and you have significant risk of having a problem and losing the vision permanently. But that also means that patients were struggling. So patients were struggling, and for a long time, actually, they were not enjoying things that they used to do. That's no longer the case. So there is no kind of rigid, I would say, requirement, for us to decide when we need to do the surgery. If you're still an active person, if you're still working, and you find it difficult for you to function as you were probably before, that's clearly an indication that for you to have cataract surgery. Then the chase, obviously, as I mentioned to you, the problem sometimes is the waiting lists and the priority we can sometimes give to patients. We obviously give priority for patients who are with more advanced cataracts or with bilateral cataracts. But definitely would recommend to you to have an assessment and just to see how what's the degree of your cataract, and if it's a certain degree or just clearly, as you mentioned, is having an impact in your life, I think definitely you should be suitable for cataract surgery. So nowadays we prefer not to delay this until it's too late, the cataracts are too thick, because it's also a bit more difficult to remove the cataracts with the techniques that we have nowadays if it's really thick. So it's more risks. I would definitely recommend you just to make an appointment or ask your GP to be referred, for you to be referred to the NHS. Even if it's not a formed cataract, I think you definitely would benefit of cataract surgery.
Lovely, thank you. We've got time for a couple more questions. So Graham and Liz have asked very similar questions. Would you recommend having both eyes done at the same time? And if not, how long between surgeries if both of your eyes have cataracts?
Yeah, well, that's a very good question. So in the past, we used to do one eye first, mainly or mostly, and just wait a couple of weeks, at least 2 to 4 weeks, and do the second eye. And the main reason for that was, obviously, we say, well, we don't want to have the same risk of infection in both eyes or the same risk of complications. And the other reason was to say, well, you know what? So once we get the results from the first eye in terms of prescription, then we can adjust for the second eye and then just improve, fine-tune the outcome. Well, that's no longer the case, because long studies in countries, actually, that we've been doing cataract surgery in both eyes on the same day have shown that the risk of infection is still minimal, is the same as if you do separate eyes. So what we do, and that's a common practice in the UK, if you decide to have both eyes on the same day, every eye is treated separately. So we have to change everything. We have to change the clothes from the staff doing the surgery, the equipment, and also just treating your eye as a separate eye if we have to do the second eye. So, and that has that usually improves the balance as well. If you have two eyes done at the same time, right? Because when you have only one eye and you have to wait, it's a bit of period of unbalance. But that depends on the patients, that depends on the units. I would say both options are okay, are good. When it comes to special lenses, the adaptation to the special lenses is more beneficial if we do bilateral cataract surgery or at the same time. But that also depends of your surgeon, right? There's not good and bad option. If it's the case that you're going to have separate days, it's usually between 2 and 4 weeks most of the times in most of the units. That is the gap, the interval time. But if you decide to have cataract surgery on the same day, that's a good option as well. So the first eye has to be perfect for us to continue with the second eye. If the first eye is, you are uncomfortable with the first eye, it's not really, you didn't like the experience, we always decide to cancel the second eye and wait until your eye is recovered for to do the other eye. Or if you have a problem or a complication, obviously we don't do the second eye.
Yeah, lovely. And our very last question is from Eric. Eric says that he is allergic to iodine. Is there an alternative that can be used?
Yes, indeed, Eric, there is an alternative. An alternative is just another solution. It's chlorhexidine. Chlorhexidine is also used, in many sorts of surgeries, and that's available. So don't worry about that. So if you are allergic to iodine, you have the alternative, and it's the same. Actually, it minimizes significantly the risk of infections during the surgery.
That's lovely. Thank you very much. Sorry if we didn't answer your question, but if you provided your name, we will get back to you by email. Mr. Perez, if we could just move on to the last slide.
Yeah.
Lovely, thank you. So as a thank you for joining this session, we are offering 50% off your initial consultation as a thank you, a call back from your dedicated private patient advisor, an email tomorrow with a recording of this session and further information, and updates on news and future events as well at the hospital. So if you'd like to discuss or book your consultation, our private patient team can take your call until 8 p.m. tonight, or between 8 a.m. and 6 p.m. Monday to Friday using the number on the screen. We'd be grateful if you could complete the survey when this session closes to improve our future events. Our next webinar is on hip replacement, which you can sign up to on our website. So on behalf of Mr. Perez and our expert team at Benenden Hospital, I'd like to say thank you for joining us today and hope to hear from you very soon. Thank you very much.